journey. We'll have some resonance in your own personal life with the points that I will be making today. So as you can very well imagine, it's the psychology of having to cope with such a huge and significant medical illness such as breast cancer is a very germane issue for all of the patients that we see and for all of us who are actually involved actively in the day-to-day management of cancer patients. But not too long ago, we actually ignored many of these psychological aspects and to the, I think, disadvantage of many of our cancer patients. A lot of it probably has a lot to do with the stigma associated with psychological issues. And thankfully, as the years rolled by in medical practice, that stigma has been less and less. And I think we are benefiting from that, that we are now able to discuss many of these very relevant aspects of the psychology and the emotional life of our patients with cancer. So I'd like to start by saying that emotions are normal. I mean, it seems obvious to us, but to many patients, whenever they have an emotion that is negative or that is unpleasant, immediately the question is, what is wrong with me? Okay, well, there's nothing wrong with us when we're feeling something. Emotions are normal, even distressing emotions. It's part of life. It's part of our coping with the stressors of the world that are being presented to us almost every day. So it's normal to react to adverse events in our lives. And in many cases, extreme reactions are rare. So in general, when we have an adverse reaction happening to us on a day-to-day basis, a negative feeling, and even some specific emotions such as crying, such as avoidance of events, are generally normal. Our reactions to adverse events are preconditioned by culture, by learning. As I've mentioned earlier, the overt expression of emotion can be seen as a disadvantage by many cultures. And I think that that's part of the stigma of mental health problems. There is in our culture a belief that negative emotions must not be shared publicly, meaning it was not a good thing to wear our emotions out openly. And because of that, I think when we do manage disorders of our mental health, there's always this silence, there's always this shame that accompanies it among many of our patients. Our reactions to adverse events are also determined by our peer group. Certain groups of people look negatively towards the idea of expressing distress publicly and outwardly. There is a belief that we must be stoic, we must soldier on no matter what. And certainly for those of us, for example, who are in the healthcare profession, that is a common belief. Dr. Zara is waiting. I think he's going to admit George. And a host of other factors in our lives, including genetics, that affect our outward expression of emotional distress. I have here a diagram of a telegram. I'm old enough to remember the telegram as harbinger of bad news. So in this particular telegram, there was news about the sinking of the Titanic, for example, such a catastrophic, traumatic event that was shared by many at that point in time. And So the harbinger of bad news is always seen as this, kind of catastrophic signal, and of course all the emotional repercussions that follow these catastrophic events are deemed understandable, and certainly one we consider normal. Okay, so we carry in ourselves, in our genes, the anxiety gene, the fight or flight gene. Our ancestors, the proto-humans, are subjected to a lot of trauma, to a lot of really distressing events in their lives. So the fight or flight gene, if you are to call that, the fight or flight set of genes is actually within all of us. The fact that we are here means that we inherited these capacities for survival from our proto-human ancestors. And so it underscores the fact that the anxiety gene, the ability to engage the fight or flight response, is in all of us. And I think that that's really the zeitgeist of many of our reactions to a cancer diagnosis. There are some physiological correlates of the fight or flight function. It's worthwhile reviewing it because I think that it really lends credence to many of the physiological effects that at least we psychiatrists tend to see in many of our patients who are in distress. For example, increased blood pressure, increased production of blood sugar for energy, and then of course a lot of GI side effects, a lot of GI problems such as gastric refluxes. Usually there's increased metabolism, and then there's a faster heartbeat, faster respiration, and in some patients with extremes of the expression of fight or flight, they can actually have panic attacks. It's one of those manifestations that we as psychiatrists often encounter in our offices and in our consult requests. There's generally a decreased protein synthesis. Intestinal movements again are disturbed, and a host of other physiological reactions that address the fight or flight function, and the function, of course, of increased blood pressure, increased heat and perspiration, and is the muscles are preparing to engage and flee or fight. So you notice that also in patients that are in distress after any kind of bad news, often accompanying bad news, tragedies, and losses. Often we hear patients complain of insomnia or sleep-wake cycle disturbances. And in fact, much of the visits to primary care physicians, to oncologists, to psychiatrists are spent about complaints regarding insomnia, regarding sleep-wake cycle disturbances. Eating changes are also common. Usually there's decreased appetite because the intestinal functioning is also altered. In preparing for fight or flight, the organism typically stops to eat in order to save energy. Eating and digestion requires quite a bit of energy, and those energies could be spent with the idea of having to deal with a crisis. In our modern times where food is plentiful, excessive eating or eating as a way to cope with problems has become commonplace. And so we actually see this bi-directional distribution of coping strategies. Some people don't eat, some people eat excessively. And there's a temporary lowered immune function. This hour is not enough to discuss the vicissitudes of immune changes during tragedies, losses, and bad news. And there's psychoneuroimmunology is a burgeoning field in all of medicine. I actually have a personal interest in immune function underpinning many psychiatric disorders, including depression. The long and short of it is severe emotional upset can alter your immune function, both increase certain cytokines and decrease others. And we actually feel it. When there's a change in the immune function, there is a cognitive and a behavioral component that the mind somehow detects when there's an alteration in immune function, especially important in oncology and cancer physiology, because essentially a big part of cancer is an immune response. Cancer is essentially an inflammatory process, and the body detects it. And often the eventual expression of the mind's detection of the altered immune function is either depression or anxiety. And a correlate of that is a diminished ability to experience pleasure. What used to be enjoyable is not enjoyable anymore, or it's such an effort to pursue usually pleasurable activities. Minor cognitive changes such as forgetfulness are also common when there is a tragedy or a bad news, or when the organism or the patient is having to cope with these losses and negative events in their lives. And this is one of those expressions that have been a trope with modern life, right? So when people know or detect that something's going on in your life, this is one common comment: "Oh, you look tired," which often is a trope for avoiding saying, "Oh, you look awful. You have bags under your eyes, and you've lost weight." So a neutral way of saying that is you look tired. And so we can actually detect people who are not doing too well. We have the sensors for that as human beings. And again, the negative events in life are losses, tragedies, deaths in our loved ones, changes in our financial and economic circumstances. You and I know this very well in the past almost couple of years with COVID-19. We've lost those of us who know friends and family who perished from the pandemic. Also, the economic losses are such, collective sources of daily negative events. And then bad news, such as illness, even if it's not cancer, if there's something that is significantly in need of medical attention, such as a need for surgery, for example, all of these negative life events can cause the physiological changes I've mentioned in the previous slide. Now, in terms of cancer, in terms of the diagnosis of cancer, these are common emotional and cognitive responses that we've seen in patients who have been recently diagnosed with cancer. Shock and disbelief. Often, many patients have that very automatic conclusion that death is imminent. So the concepts of death and cancer seem to go side by side in the existential coping with the diagnosis. And with that, if the patient is not able to tease himself or herself away from that kind of dire conclusion, inappropriate actions may ensue, such as giving away of possessions, some of these dramatic gestures, saying goodbye to loved ones. We've seen that happen often and actually can trigger psychiatric consults sometimes, rightfully so, because you're always thinking, well, maybe suicide is right around the corner. And of course, we don't want that, especially right at the get-go, and we just don't know what the biology of the specific cancer is at the moment, and we still need to do a lot of diagnostic tests. So patients can sometimes jump to conclusion. Needless to say, the diagnosis of cancer triggers the fight or flight physiological response that is hardwired into us, as I've mentioned earlier. Because of that, there's temporary paralysis of problem-solving skills in patients who are coping with the shock and disbelief. And again, the mechanism for that is that the organism is trying to save energy. So the patient is not going to try and figure out where they placed his or her wallet or purse, where the car keys, and this little forgetfulness and absent-mindedness sometimes add to the distress of the patient, and can also produce its own secondary catastrophic thoughts as, oh my gosh, am I getting demented at the same time? Is there metastases to the brain already? All of these automatic thoughts might happen. Extreme reactions may be preconditioned by outmoded ideas regarding the prognosis of cancer and the bad effects of treatment. So many of our patients have had experiences with cancer treatments in their loved ones, maybe from a generation ago, when the treatments are not as advanced or are not as well thought of or modern, as it were. And I'm an example of that. Many of my family members died with cancer, and I've seen some harrowing effects of some of the treatments that they've been through a generation ago, 10 or 15 years ago. So many of our patients may have that same experiences. They've watched someone else be treated with a less advanced form of protocols that they have kept in their minds. And they might be fantasizing that that's also their future when they have been diagnosed with cancer themselves. In terms of breast cancer, the common and emotional cognitive responses that we see in our clinics as psychiatric oncologists are grief and sadness about changing roles, motherhood to non-motherhood. The breast is certainly a metaphor for nourishment and mothering, and being treated for breast cancer becomes also a metaphoric sign for the changing of that role, for the passage of time from fertility, nurturing to another role. There's also anxiety about suffering from the treatment, about whether or not this forms of suffering that patients often imagine are real or not. It happens and can give a whole lot of anxiety to the patient at the point of diagnosis. There's also anxiety about shortened life, anxiety about pain related to the treatment, and of course, grief and sadness about plans that may not materialize, given that the treatment and the subsequent coping with cancer, for example, as a chronic illness, really alter the course of people's plans with their careers and with their families. It can alter all of those plans that they've made. Body image is a problem. Is changing body image from a neutral or a good body image to a negative body image is common at the onset of the diagnosis. Financial worries: can I afford this treatment? How is this going to affect my job? Am I going to need to move, sell my house, etc.? And these worries are certainly much more magnified for people that are alone, that are, have their families have already grown and are on their own. People who are divorced or people who are single may have had some tragedies in their relationships. Also, those are people that might suffer through a magnified form of these worries. And then, of course, because of the body image issues, because of the anxiety and possible depression, sometimes there might be changes in their relationships with their partner. There might be consequential deterioration in communication and in the intimate relating to a partner. Now, the good thing is that the risk factors of these adverse emotional circumstances can be potentially outbalanced by resiliency factors in our lives. What are resiliency factors? These are the things that might potentially balance the negative effects of a cancer diagnosis. And these are family and social support. Number one, one of the big determinants of overall health is the robustness of one's family and social support. Good general physical health is certainly very, very important. These are the most important things in resiliency, social support, and physical health. And then, of course, a stable home environment. If you have recreational pursuits, if your life is rich with many different facets and you're not over-invested in one area, such as work, then your resiliency factors are certainly more compared to those who do not have these recreational pursuits. Your basic attitude towards crisis resolution and problem solving also count. If you have the attitude of saying, well, let's try and resolve this crisis step by step versus getting overwhelmed and getting very negative about it, then you have an edge in terms of your resiliency. And then, of course, a rich spiritual life, religious beliefs, study after study seem to prove and indicate that they are associated with good prognostic factors in terms of the quality of life when you have a cancer diagnosis. And this is a diagrammatic representation of what I had just said. So if you look at it as a balance, the stressors tend to push you down, the protective factors or your resiliency factors push you up. And the hope is that you're going to have a balance in your life that might help with coping with cancer. So the risk factors of cancer diagnosis and emotional negative effects are pre-existing emotional and psychiatric issues. Those are risk factors. The protective factors or resiliency factors include support systems, as I've mentioned, personal resiliency factors, your own personality, your own ability to solve problems, stable physical and emotional health, and this is very important, your connection, your engagement, your ability to relate and communicate to your treatment team, i.e. your oncology team also portends a good degree of resiliency. So your treatment team, I think one of the primary goals for the cancer team is to develop a good rapport with your patient and the patient to your team as well. So as you know, modern medicine is now team sports, right? So and the oncology team is no different. Modern cancer treatment is team sports. It involves multiple people, multiple disciplines. And that team includes the patient and the family. So if this team relates to the individual members in good ways, then it portends a good outcome. I think that statement is self-explanatory. You live it day to day. You may not know it, but I think that the cancer team always strives to have a good relationship with the patient and the family. Now, in terms of effective coping, self-care is number one, and this is one of those things that we have to do ourselves as professionals, as healthcare providers. It's also something we should teach our patients, and it seems obvious, but I'm always surprised that we don't take care of ourselves adequately enough, and our patients don't either. Many of them don't. So this is called from Maslow's hierarchy of needs. At the base of the pyramid are basic stuff that you cannot do without. And the absence of these basic factors really portends a worse prognosis for many illnesses in general, and including cancer. And that includes safety, that includes the basics of food, shelter, and clothing. And safety, of course, includes shelter, right? So the homeless population, the people that are dispossessed and underserved and poor, really have study after study show worse prognosis across many diagnostic categories across the board. And of course, how can you even think about self-actualization when the base of the pyramid is not taken care of? So I think to understand this concept is understanding a lot and really contributing to our patients' well-being. I present these slides to my annual lectures to residents of many specialties, and you'd be surprised that some of the people that really falter quite a bit on their self-care skills are actually healthcare providers. We're so used to giving, we're so used to not thinking of ourselves, that if we miss a couple of meals during the day, we don't even think about it, if we're too busy. So you know what I'm talking about. So I think one of the ways that we can treat our patients is to be role models for them, that we have to make sure that we take care of ourselves. In terms of effective and ineffective coping, I think it's worthwhile to review cognitive and behavioral skills. Thoughts, feelings, and behaviors are very much interrelated. So thoughts are how we interpret events, and an event, for example, is a cancer diagnosis. And if you come to think of it, in and of itself is relatively neutral. You have a medical diagnosis, but how we interpret it individually is the one that really portends how we feel about it. And how we feel also dictates how we behave. And this is an example of an ineffective coping in a breast cancer diagnosis. In cognitive behavioral therapy, we call this the awfulizing cognition. So the thought is, this is awful, I will not be able to weather this. So this is also an example of the cognitive distortion called predicting the future. I mean, we cannot predict the future. I can. But in this particular automatic negative thought, this patient is actually, excuse me, sorry, is actually predicting the future that he or she will not be able to weather this particular challenge. And of course, Logically, the feeling is anxiety and depression. The behavior, withdrawal, paralysis, inability to function. And I might add in there this, that this patient could be potentially at risk for noncompliance in terms of the treatment recommendation. The behavior follows the feelings follows the thoughts. So what are some signs and symptoms that a professional might be needed in terms of dealing with the mental health symptoms after a cancer diagnosis? So these are signs and symptoms we all need to watch out for in our patients that have been recently diagnosed. Prolonged inability to function, long hours spent in bed or poor sleep for many days and weeks. Sleep is one of those things that we're always nagging patients about and monitoring patients because it's a basic physiological indicator of functioning. Not eating or eating excessively, suicidal thoughts, or a wish to not wake up. Suicidal thoughts are certainly not binary. It's either you have it or you don't. You know, it's a range. Sometimes it starts with a wish to not wake up. It can progress into actual suicidal thoughts, aggression towards the self, self-harm episodes, or what we call chronic suicidality. Sometimes it can be interpreted. For example, people who are chronic harmful drinkers. We can sometimes interpret that, depending on the context, as chronic suicidality because it's self-destructive. Not taking care of the self, not showering for days, neglecting work and family responsibilities, extreme irritability, anger, acting out, or personality change. I had a patient once who started going to Las Vegas after a cancer diagnosis, started flying out there. He happened to have an incipient gambling addiction, which was in remission for a while. And when he had a testicular cancer diagnosis, he vanished for several weeks and was in Las Vegas, spent a fortune, came back for treatment. So those kinds of really bothersome behaviors need attention as soon as possible. Constant worrying and obsessing about the diagnosis and dire events from the treatment, the catastrophizing, thinking about death, thinking about pain, even though the treatment has not even begun. And a big potential indicator of a need for professional mental health is the previous diagnosis of a serious mental health crisis or illness, such as bipolar disorder, borderline personality disorder, psychotic illness. Those are just some of the categories that you may see as previously existing in patients who've recently diagnosed with cancer. And again, those are possibly reasons to get a psychiatric consultation. Now, in terms of breast cancer, what does the data show us about common psychiatric disorders? About 10 to 22% meet criteria for major depression, PTSD, or adjustment disorder. So those are the three major psychiatric illnesses that have been noted in patients with breast cancer. The risk factors for a psychiatric diagnosis are previous diagnosis of a major depression, personality factors such as neuroticism. Neuroticism in terms of personality psychology is a fancy term for the tendency to a lifetime tendency to be anxious or to worry about even little things. We call it neuroticism in personality disorder research. The presence of helplessness and hopelessness. And you're going to say a whole lot of patients might have helplessness if they don't have support, for example, or if they cannot afford it, they don't have insurance. And there's always that overwhelming kind of sense of helplessness, which is contextual given the circumstances. And those are actually risk factors for major depression, PTSD, and a host of major psychiatric illnesses. In research on common disorders in breast cancer, it seems that there's a higher prevalence of anxiety disorders compared to depressive disorders. So in terms of body image problems in breast cancer, up to 50% is a whopping percentage of patients with breast cancer diagnosis will experience at least temporary issues with changed body image. Their bodies have changed, and it's not for the better. Certainly, it's for the worse. And because of that, it can lead to other issues such as self-esteem, such as problems with their relationship. It correlates with low levels of self-compassion. So studies have suggested that those who are at risk for significant body issue problems are those ones with pre-existing levels of the capacity to be compassionate to the self. So they tend to be, if you are to look at the reverse of that concept, these are people who tend to be self-critical as a baseline, or poor self-esteem. Understandably, they can affect sexual functioning and intimacy issues with their partners, and it can lead to other secondary problems such as relationship problems. So even though only about 20%, 22% will lead to a serious medical problem, psychiatric problem, we are now, as a standard practice, we need to evaluate everyone in terms of the potential for a serious coping or mental health issues related to a breast cancer diagnosis. They always start with the primary care or with oncology. We do the distress temperature, or a kind of a very general assessment of whether they are in distress or not. We do some psychosocial screening, such as the quality of life screening or the Beck Depression Inventory. And if they score high enough, then they are referred for possible psychological evaluation. We do have it at Norwalk. Michelle Daly is certainly at the front line, and in the breast cancer patients. Mary Heary is so used to all of these by now, in terms of the protocols for the detection of these potential problems in our patients. Counseling by licensed social workers, counselors, and psychologists often happen for those patients that are in need. And so for those ones who don't respond, or who the social workers, the nurses, and the counselors think might be in need of psychiatric evaluation, are referred to us. And we evaluate whether medications might be needed, whether psychotherapy might suffice, or maybe both at the same time would help the patient. So this is the usual flow of the referral process when we detect that there might be some mental health issues in patients that we diagnose. And this is this slide actually illustrates the distress thermometer. The patient circles the area that best describe how much distress they are in this range. It ranges from 0 to 10. I think the visual of it being a thermometer is actually quite good and helpful for patients to indicate more accurately where they are in terms of the level of their distress. And then, of course, they specify which domains of their lives are especially stressful for them. This is something we do routinely. And lastly, what are the usual medications? Again, the pharmacology is beyond the scope of this talk. I'm sure many of you have seen this. In psychiatry, medications are sometimes needed to help the patient who are in distress, who are actually already diagnosed with a major depression, with a generalized anxiety disorder, and other psychiatric diagnoses. In psychiatry, we don't medicate the diagnosis. We medicate the symptoms, depression, anxiety, hopefully not psychosis. In terms of PTSD, there's usually a combination of many different symptoms, including anxiety, insomnia, nightmares, that which we call flashbacks. Some patients might require a combination of medications, and some patients might already be on medications prior to the diagnosis, and we will discontinue them and monitor them. So that is the last slide I have. If there are any questions that I can answer for you, I'd be more than happy to try and answer them.
Dr. Trinidad, I had some questions come in.
Sure.
One is, could you please give us some tips on how to deal with anxiety?
First of all, I think you have to do a bit of self-analysis what the anxiety is about. Anxiety is a symptom. It's just like fever. Okay. So when you have a fever, what do? You also do a bit of a self-analysis, right? Have I been exposed to someone with a fever? Is this infectious? Then you measure your temperature. Is this fever, or do I just feel febrile? And so you try and search for answers. And if you cannot find the answers, then you go to the doctor, and the doctor does the same thing, or the clinician. Blood tests, history. So it's the same thing with anxiety. So if you have been diagnosed with breast cancer or other cancer, and you have a significant anxiety, that is, remember, anxiety up to a certain point is normal. Okay, anxiety is a sense of worry. Anxiety is a forward-looking affect, meaning we're worried about something that might happen in the future. And having said that, then analyze yourself. What are you worried about? List them down. Okay, and then decide for yourself: is this an excessive worry, or is this something that is just overblown? Okay, so. And when that happens, what are the facts of the case? What are the facts of your cancer? Often when you look at the facts, the anxiety goes down because the facts usually do not support the overblown worrying that we do all the time. Okay, so to answer your question, as a tipster, do a self-analysis of your anxiety. What is it? What is that about? What are the elements of your life, the domains of your life that you are anxious about? And the second part of that tip is to see whether the facts support the worry that you are investing on the issue.
So I actually have a question. So, in your first slide, you talked about some of the various emotions that people go through when they're diagnosed with cancer. And one of them is that struck me was being stoic. So frequently patients will come in and they will say that there's an outpouring of different emotions and suggestions, all well-meaning, that come into patients from their family, friends, people they work with, and much of it is well-meaning, and most of it is directed towards having them be stoic. And people come to me and they just feel overwhelmed, and they feel they really feel overwhelmed, worried, all those kinds of things. So what kind of strategies do you have to sort of manage all of those well-meaning people around them that want them to be stoic when really they're scared?
So I think that what I would suggest, Linda, is to tell these people that are around them, exactly what you told us just now. Okay, sometimes being stoic, sometimes some of this advice is not helpful. Sometimes it is useful to let the patient express their distress. They can cry, they can, they can express everything that they want to express, their fear, their anger. It's okay to let go of that, and don't. Sometimes being stoic is actually harmful. In exactly the same words that you just told us now, is I think might be useful to the people that are trying to help the patient, and really to give a permission for patients to be emotional.
Thank you. So we have a few questions that have come into the chat. And so one of them is, how do you determine when someone may need a higher level of care?
So if you really think you need a higher level of care, say so. So I think it's better to be cautious than not cautious at all. So if you feel that, I need to see a psychiatrist, I need to see a social worker, then go ahead and ask it. And if the social worker says, well, this is really normal, then fine. Okay. But I think it's better to err on the side of caution. So that I think that's a good rule. Secondly, talk to the people that know you best: your husband, your wife, your mother, your father. Okay, with a caveat, of course, sometimes they can be well-meaning, as you're saying, Linda, that they can give you a well-meaning, but the wrong advice to be stoic. Okay. But sometimes it's helpful. What do you think? Do you think that, are you seeing anything in me that you haven't seen before? Have I changed? Do you think I'm doing okay? So get the feedback from people that know you best and whom you think will give you an objective evaluation whether you are in need of help or not. But again, err on the side of caution.
So we have another question that came in, and basically discusses that this participant doesn't feel like doctors like to use Ativan or marijuana, and I guess I'm assuming for anxiety or just for any emotional issues. And so my sense is from the question, they want to know, like, why is that? Does it not help?
Can you repeat the gist?
Yeah,
Linda?
yes.
Why is what?
It says, I feel like doctors don't want patients to use Ativan or marijuana. Why is that? It doesn't help?
It helps, but it has side effects, okay? And one of the side effects is the brain kind of habituates to it. And the brain changes so that after a while, after a period of time, it differs from person to person, then you become dependent on it, okay? And dependency is, to achieve the same effect, you need more and more of the medication or the marijuana. So then it becomes problematic because if you start with 0.5 milligrams of Ativan and after a year, you're going to need 4 milligrams. At that level, it will have other effects, such as it's a high dose of Ativan is actually associated with depressive episodes. So then it has diminishing returns over a period of time.
So along those lines, there's another question about a patient who has debilitating anxiety that interferes with functioning, but wants to handle things on their own and they're opposed to medications. How would you counsel someone like that?
So professional help doesn't immediately mean medication. Professional help can mean cognitive therapy, can mean DBT, hopefully a comprehensive evaluation. There might be other factors that are masquerading as anxiety, because again, anxiety is just saying fever. It could be because of many different elements in a patient's life, right? So again, it doesn't mean that you will be medicated immediately. It could mean psychotherapy, it could mean counseling, it could mean environmental manipulation to change the environment.
Another question regarding regarding loss. So this participant is asking, does anyone address the cycle of grief that naturally occurs with loss and how to complete and resolve it?
So each is different. I think we're all different people. Certainly losing a partner is different from losing a friend from a long time ago. Losing a parent is different from losing a child. Losing a friend that you've known since high school is different from losing a friend that you've known from a year ago. So I think that there are different gravities and contexts in losses. So each loss is different from the next. So I think every approach is individualized. There's no real unified cycle that applies for all of us. I think the Kubler-Ross model from the 1960s, they probably apply to a small segment of the population, but it certainly does not apply to everyone. There are no specific, stages that one goes through. So we have to talk about exactly what the loss means to you, and what have you lost, and what are the blockades in your personal life that prevent you from moving on.
Mhm. Okay, so I think we're out of time. It's 6:30. So Dr. Trinidad, a million thanks for spending time with us.
You're very welcome.
We really are so happy to have you, and we've learned so much. And just a reminder to everybody that we have our next meeting on this, the second Tuesday of the month, November 9th. And at that time, Qing Bao is going to be talking about alternative and complementary medicine within breast cancer. She runs the breast cancer integrative medicine service at MSK. So I think I think we'll learn a lot from her also. Okay, so with that, we'll close out the meeting. And thanks again, Dr. Trinidad, and thank you everybody for taking the time to listen and to learn more. Take care, everybody. Bye-bye.
Take care. Good night.
Good night.